And may I now invite Dr. Viney Gupta to talk to us about artificial intelligence and management of juvenile glaucoma. Dr. Viney?
Yeah, thank you.
Just give me a minute, sir. Yeah. Dr. Viney Gupta?
Yeah, I'm here.
I can't see you. Yeah, I can see you, sir.
Yeah. So I hope my my screen is visible now.
Yes, your screen is visible, sir.
Thank you. So basically, I think I'm going to talk about glaucoma, which and particularly juvenile glaucoma, primarily because it's not so uncommon in this part of our world. So, so as I said, we do get to see a lot of patients of this disease, that is juvenile glaucomas, in India and in South Asia. And unfortunately, because it's not so common in the Western world, we don't know much about this disease. And since this happens in a socially productive age group where a lot of these patients are young, a lot of these people are someone's father, someone's son, someone's husband. So managing these patients becomes very important because it's a very socially productive age group. And therefore, the economics of managing this disease is important. It's also important because the genetics of all the glaucomas actually began with this subgroup of diseases, which was the juvenile glaucomas. So as I said, in our part of the world, we see at least about 3 to 4 such patients for every 100 new glaucoma patients that we see, which is much larger than what is there in the Western world. And if you see our population structure is such that a lot of us are in a young age group. So if you take the numbers, there are very large numbers that we have to deal with. So what is known in literature is that it is an autosomal dominant disorder, which is associated with very high intraocular pressure, a very concentric deep cupping, which leads to a generalized visual field loss and a lot of disability at a very young age. So this is how the patients present to us. They present with very deep, steep cups at a very young age when the visual fields may not be so bad. But at the other end of the spectrum, we have patients presenting at a later age with the same kind of cupping, but with a very severe visual field loss and very high intraocular pressures. So what we described gonioscopically while we did gonio-photographs of a lot of these patients, we found that there is some amount of dysgenesis of the angle in the form of a high iris insertion or an angle which is absolutely featureless, which is caused by the trabecular beams being extremely thick and compact, so much so that they gave the appearance of ground glass appearance, which Barkan described as a membrane. And if you histopathologically see this trabecular meshwork, it actually appears like a membrane. And then there are others where there are mixed kind of features, gonioscopic features. And finally, then there are about a third of these patients which have absolutely no gonioscopic abnormalities and are just normal primary open angle glaucomas. If you see, almost 2/3 of these patients will have some amount of angle dysgenesis. And we did ASOCT, very high definition ASOCTs of these patients. And you can see this membrane kind of a structure here at the angle, which was seen in a lot of these patients who had abnormalities of the angles. And sometimes you can even see them in a unilateral case of juvenile open angle glaucoma too. They present in a very different way. These are all anterior segment photographs of different patients with juvenile open angle glaucoma. See how the iris looks in all of these patients. See the prominence of the crypts in these particular patients, unlike the upper two irises where the crypts are not so prominent. So basically, they're not all alike. And unfortunately, as I said, we do not know much about it. What is written in literature is anything which is open angle less than 40 years is to be labeled as juvenile open angle glaucoma, but then they're not all the same. Therefore, we used artificial intelligence. We used cluster analysis to kind of classify these patients into different clusters based upon their gonioscopic appearance and their iris features. And we found that they formed 4 clusters, basically. Those which were associated with a normal looking iris and a normal angle, those which are associated with some dysgenesis in the form of immature angle. And then there were those who had a normal looking iris, but a very high iris insertion. And finally, we found this particular cluster, which had a very prominent crypts of the iris and a very high iris insertion. These were the ones which presented with a very high intraocular pressure. Almost 70% of these juvenile glaucomas had intraocular pressures above 50 millimeters of mercury. So this leads us to the genetics, because there are different kinds of juvenile open-angle glaucomas, and unfortunately, only 30% could be explained by the myocilin gene. The myocilin was the first gene for glaucoma that was discovered, and it was discovered in a family of juvenile open-angle glaucomas where a large number of these people were affected with the disease. And even in myocilin, there are certain mutations which are associated with a more severe kind of disease compared to the others. So when we looked at our data of juvenile glaucomas of more than 300 families, we found that actually there were not so many were autosomal dominant. In fact, most of them were sporadic cases. So this was interesting because this brings us to other genes which could be involved. And when we screened them for myocilin, we found that myocilin, as is known, was present only in 30% of the cases. And in some patients, there were CYP1B1 mutations also, which means that we need to look for other genes that are associated with this disease. Now, because this glaucoma happens at a very young age, you need to distinguish it from pigment dispersion glaucomas, steroid-induced glaucomas, congenital glaucomas that can spill over and appear as juvenile glaucomas. Patients with trauma sometimes will have very high intraocular pressures in one eye. Sometimes certain uveitic glaucomas, which are extremely very silent, looking like Posner-Schlossman, could be mistaken for a juvenile glaucoma. Sometimes primary angle closure glaucoma in a very young age, unless you do a gonioscopy, you will not be able to differentiate it from open angle glaucoma. Then there could be cases of axon field rigor, which are very subtle forms of axon field rigor that need to be distinguished from juvenile open angle glaucoma. There could also be patients who have been born prematurely and have very large cuppings. They can mimic a juvenile open-angle glaucoma also. And then there is a subgroup called the juvenile normal tension glaucomas also, which have just normal tensions and cupping with visual field effects too. So all of these need to be distinguished before you actually diagnose them. As far as management is concerned, a lot of people think that because it happens in young age, so surgery is the mainstay of treatment, but almost 2/3 of these can be managed medically actually. Regarding laser trabeculoplasty, it is controversial. Some people think it works, the other things they don't work. As far as surgery is concerned, there are different kinds of surgery, including the minimally invasive glaucoma surgery that are being propagated. But because these patients are presenting at a very young age, it's important that we do a surgery which is long-lasting, and trabeculectomy with or without mitomycin is still the gold standard and really helps to control intraocular pressure in the long term. As far as laser trabeculoplasty is concerned, we did it in a few eyes and we found that it does work in about 30% of the cases, and it's worth a trial. But it was those patients who actually had some amount of angle dysgenesis where the trabeculoplasty was not so effective. And therefore, we published this where we found that if you do ASOCT and you can actually pick up angle dysgenesis on ASOCT, you can then say whether this particular patient is going to respond to angle surgeries, either SLT or any type of mixed surgeries. As far as trabeculectomy is concerned, the eternal question is to use or not use mitomycin in these young patients who are presenting with a primary open-angle glaucoma. After having followed up a lot of these patients over 10-15 years, we've realized that use of mitomycin really helps in bringing down the pressures and producing low diffuse blebs. As far as long-term follow-ups of these patients are concerned, actually, they don't do so badly. In fact, 10% of them are only those who are going to progress. Majority of them maintain the good intraocular pressure, and the risk of perimetric blindness is also not very high, because a lot of these patients, when you bring down the intraocular pressure, the intraocular cupping, the glaucomatous cupping actually reverses. So unlike certain normal tension glaucomas, pseudoexfoliative or angle closure glaucomas, which progress extremely fast, the progression rates in juvenile glaucomas are not that bad when they are treated. But unfortunately, there are patients from low socioeconomic groups who actually present with very high pressures and blindness at a very young age, probably because they are not screened. This is not the age where you would screen patients for glaucoma. And unfortunately, there are about 10% that come to us which are bilaterally blind as well. And these are those patients who are very high intraocular pressure, and as I said, from a low socioeconomic group. So therefore, to summarize, I would like to say that there are certain features that we need to find out to distinguish which patients are going to do worse compared to the others. We need to properly classify them, as I have just tried to do so with our artificial intelligence. We are looking for genes other than the myocilin that could be responsible for a lot of these cases. And of course, we need better management techniques. We have this survey article, if anyone is interested in reading about juvenile open-angle glaucoma, and we have concisely given all the latest updates on this disease. This is our team. We've been working over 15 years in this particular disease. And finally, those who are interested in juvenile or pediatric glaucomas, we have a society called the Indian Pediatric Glaucoma Society, which we invite you all to join. Thank you.